I am Kim Nitz, and I want to welcome you to our Parkinson's Foundation Wellness Wednesday. I'm on the community programs team for the Parkinson's Foundation, and today we're pleased to bring you a DBS Care Partner Town Hall. We have a great turnout for today, and we welcome everyone. As we begin, we want to take a moment and just share the mission of the Parkinson's Foundation. Every day and in everything that we do, we're working to make life better for people with Parkinson's. To achieve that mission, we pursue three goals. Those are improving care for everyone with Parkinson's, advancing research toward a cure, and empowering and educating our global community. Today's program is a great example of one of the things we're doing to help meet those goals. Today's program is brought to you by Abbott, whose generosity has made this programming possible. We want to thank them for their support. I also want to let you know we have started a new initiative to capture the community's perspective on various topics in Parkinson's disease, such as mental health, telehealth, cannabis use, and other. By signing up for this initiative, we'll email you up to 4 times a year asking you to complete a 10 to 20 minute survey. We'll always report the findings back to the community, and we encourage you to visit the link on the page and in the chat for more details on signing up for this initiative. I am now pleased to welcome our speaker, Clarisse Goas. Clarisse graduated summa cum laude with research distinction from The Ohio State University in 2008. She completed her MSN in 2012 in adult health. After practicing for 4 years, her father was diagnosed with Parkinson's disease, which led her to subspecialize in movement disorders. She worked for 4 years at Wake Forest Baptist Health in Winston-Salem, North Carolina, working with the movement disorder patient community. She then returned home to Ohio and began work at the Ohio State University Wexner Medical Center in the Advanced Therapies Clinic in January of 2020. Clarisse has experience in clinical trials, deep brain stimulation, and duopa, and we are thrilled to welcome her here today. And I'll turn it over to you now, Clarisse.
Hi, thank you so much for that warm welcome. It's always a pleasure to give any talk for the Parkinson's Foundation. As Kim so nicely and kindly introduced me, I am not only a provider, but also a caregiver myself for my dad. So these topics are always near and dear to my heart. So today I'm going to talk a little bit about Parkinson's disease and deep brain stimulation and some of the questions that come along with that. Usually this talk takes me a long time, so I am going to shorten it because I think that it's really important for you all to get the chance to interact with some folks who are caregivers to some folks who have deep brain stimulation and be able to answer some of those questions. So what I'll start with a little bit is, when do we start making the decision to have DBS and why to consider it? I know often in my clinics, my patients say, oh, no, I'm not bad enough. That's for what someone has deemed late stage Parkinson's disease, which actually doesn't exist. I always kindly remind them. But it's not. It really is not a last moment option. It's actually better to do at certain times. And the times are as listed there. So if you're having a lot of off time, we have a lot more medications than we used to, with the extended release carbidopa, levodopa, and Rytary, and just a lot of different medications that have come out in the past 3 or 4 years. So if you're taking those and you're still experiencing a lot of that up and down time and a lot of off time, that's a good reason to do deep brain stimulation. Same thing if you're taking, maybe you're having on time, but you're taking pills every 2 hours or every hour or every 2.5 hours. That's a really hard way and difficult way to live your life around a clock like that. So that's still a good reason for deep brain stimulation. Tremor is fickle, and we can try a lot of medications, as some of you have probably experienced, and sometimes they don't really respond to medication. Maybe it responds a little bit, but not a lot. So tremor is always a good indication for deep brain stimulation. Dystonia is not as common, but in our young onset folks, they can have more dystonia. than our later onset Parkinson's disease patients. And so that's kind of that muscly spasm things. If your foot wants to constantly turn in, a lot of times that's where we see it. We can also see it with the toes curling under, curling up, although not such a reason for deep brain stimulation, but any kind of dystonia that's not responding or not responding to Botox or medication, things like that. And then, of course, bothersome dyskinesia. So your medicine works, but it works too well, and you're constantly wiggling and fidgeting and you can't sit still. That is another wonderful reason for deep brain stimulation. So those are reasons for that. So just to help your loved one figure out whether it's time for DBS, these are some good times to start bringing it up, especially if you're seeing a local neurologist or a neurologist that's not movement disorder trained. They also sometimes think of deep brain stimulation a little bit later, just because it's not something that they see every day. So, these are also good points to bring to your local care provider if you need to start bringing up that conversation of DBS. Next slide, please. So then you make a decision that you would like to consider moving forward with DBS, but it becomes really murky of what do I do next? What are we supposed to do? So typically what will happen is you will see someone from the movement disorder specialist part, and they will do, this is done in a couple of different ways depending on where you are, but essentially at some point you will have an off medication exam and an on medication exam. And this helps us to know if DBS is going to work for you specifically. So it's really important. Sometimes it's done in the same day. Other times, you'll see one provider when you're off medication, and then you'll see another provider when you're on medication. You might have some imaging that's done, sometimes, usually a brain MRI, but sometimes a head CT, but you will eventually have an MRI most likely. You will then meet with the neurosurgeon to discuss surgical risks and what device and how many batteries and where are we going to put this thing and all that kind of thing. You will often meet with a neuropsychiatrist or a neuropsychologist, one for any mood concerns, because that's very common with Parkinson's disease, but the neuropsychologist is for cognitive testing, meaning we want to make sure that your brain is strong enough to go through this surgery. So it's not, you don't have to get 100%. I always warn everyone, this is not something that you need to ace. We expect you to have some trouble with certain parts because of your Parkinson's disease, but we just want to make sure that your brain is strong enough that if we do this surgery, that you're going to pull through very well. Then there's always the team, typically. So the whole team of everyone that has seen you, and typically there's a second team. There's usually doubles of most folks on the team. Everyone meets to discuss your case. And the only reason typically that we wouldn't go forward with something like this is if we thought that A, it wasn't going to help, or B, that it was going to do you more harm than good. So we wouldn't want to move forward with something like that. So typically we decide to move on, and then someone will call you and tell you, and then they will schedule so many things that your head might swim. So this is really where you can be helpful with as a care partner, because they're going to be ordering lab work and head CTs and surgery scheduling and follow-up programming appointments. And you just really need to have your date book ready and get to figuring all of that out. So next slides, please. Okay, so DBS has become more complicated in the past couple of years. DBS is not new. It's been around for at least 30 years, if not a little bit longer. And so this is not a new therapy. This is not experimental, but probably up until the last 5 years or so, there was only one company that made DBS. So it made things pretty clear cut. Now there are 3 companies that make DBS, which is good for everyone because the technology is moving forward very quickly, which is a good thing. Where lots of problems have been solved since some of the initial since 30 years ago, obviously, and just a lot of changes have happened. So this is a conversation that we're starting to have more and more frequently. So when we're thinking about which device we want to choose and what we want to do, there's some things we need to consider. First and foremost is whether you want a rechargeable or a non-rechargeable battery. So this means that when you have DBS, they place a little battery underneath your skin. It looks like a pacemaker if you've ever seen one in your chest. And the question is, do you want to be able to ignore this thing every day, but then at the end of, say, maybe 2 to 7, depending on the company and the device and lots of other things, 2 to 7 years have to go in for an outpatient procedure, but still a surgical procedure with anesthesia, and have it removed and a new one put in? Or would you rather have a rechargeable device where maybe 5 minutes a day or an hour a week, depending again on lots of circumstances, that you have to recharge this thing? You have to wear a thing around your neck that has a little battery recharger in front of it, and just let it charge up. Those batteries typically last at least 15 years without having to be replaced. So that's a good question that you kind of need to work with and think about how your daily schedules go and what would work best for your family. And then directional versus non-directional. So this is kind of a question that has resolved itself just in the past couple of months. But now all of the companies, all 3 of these companies have the option for directional leads. This is really more something for us on the clinician side, but it's good for you to know that it's out there. It just means that directional means that there are more ways for us to program to avoid side effects or bothersome, really side effects, to decrease side effects pretty significantly. And that's really helpful. Between the 3 companies, one of them offers the ability to have remote programming. So this might be really important to you if you live far away from where you go and see your specialist. So this has just come up also probably in the past 6 months. So it's just the difference between asynchronous and versus synchronous programming. They did a little survey and found out that about 80% of patients would prefer to see their own provider for programming without coming to the office. And up until about 6 months ago, that was impossible. But now we do have the ability to program remotely. Now, that doesn't mean that we could program everything remotely. You would still have to come into the office for certain visits and things of that nature. But it does mean that if you're doing a lot of traveling, that we would be able to do some of those smaller in-between visits with an iPad. And we see your face come up, just like most of you have seen with COVID, like FaceTime or Zoom or whatever you may see. And I can, from my office, connect to your battery in your chest at home and make changes to your device from there. It sounds very bizarre and we're all getting used to it, but it is really can be a great option, again, especially if you live very far away from where you're being seen. And that way you don't have to see another local provider who may not be as skilled in deep brain stimulation and still get all the care that you need. And something else to keep in mind, this is again something that we think of, but there's more than one place in the brain that we place deep brain stimulators. So just in case your story doesn't line up with somebody else who's had DBS, maybe someone was able to reduce medications and you weren't able to reduce medications. These kinds of things can change depending on where we place the stimulator in your brain. We put them in different places for different symptoms. So I won't get into that, but next slide, please. Oh, so this is what the virtual, I just wanted you guys to have a quick picture of what the virtual programming looks like. Very new, as I said, to all of us, but you have a patient programmer. Oh, you can't see me pointing at the screen, but so you have a patient programmer. And as you'll see on the other side of the screen is the larger iPad looking thing. That is our programmer. And thank you very much. And your face will pop up just as this nice picture has it here. And our face will pop up on the patient programmer. So we can see you. We will have you often do some of those things we have you do in the office, like tapping your fingers, opening and closing your hands. We might be looking at tremor. So as a care partner, if you are a really good video photographer, that's very helpful for us. So that we can see, because oftentimes it's hard to hold something and do those motions at the same time. So that can be very helpful. But yes, we can actually connect from far away. The good news is that, there's all kinds of safety things. So if we would get disconnected, which knock on wood, I have not had the trouble with any disconnections yet. But if we would, it just resets to the program you were on before. So no problems there. Okay, next slide, please. Okay. So now you've had DBS and you are wondering, well, actually right here, you're wondering what is the worst part about surgery. So every single patient I ask, they tell me the worst part of surgery is getting the halo on your head. So getting those tiny little pinpricks. So it's kind of like when the dentist gives you Novocaine, but they're going to do it what feels like a million times. But it is not, I promise you. It's usually 7 to 10 maybe, but they're going to prick you with a very tiny needle all around the front of your face. And then they're going to put on a head frame, which has gotten much smaller. It's very tiny. It actually looks like something made out of constructs, I think. They're not like the 1980s when they looked like field goalposts and they were very large. They're very small, but they are going to put that onto your head because it's very important, obviously, that they know where everything is in your brain while they're operating on it and that everything is very still. The second worst thing that patients report is awful is the sound of the drill. So it's not everyone does surgery differently. So some folks are asleep during that portion and some folks are awake. It's just loud. If you've ever thought of how loud something might be when it's that close to your ear, you probably haven't. And so it's just a very loud noise. My patients don't say that the actual drilling is uncomfortable or that is painful, but the sound is obnoxious. And then actually the least reported most bothersome thing that patients report to me is that, they will be shaving at least some, if not all of your head, and that you will have 2 small bumps that in general, only you and your hairdresser will know about once your hair has grown back in. But you will have 2 small bumps. About the hole that they drill is somewhere between the size of a nickel and a quarter. And then they put a plastic plate over it. My patients ask me all the time why it's plastic. Shouldn't it be stronger? No one has ever had any trouble with it. It's very hard plastic, I assure you. It won't move or break or anything like that. So one of the most important things that you can do as a care partner is to remind your significant other or loved one that they need to rest, because they actually will feel a lot better after their initial surgery, even before the battery's in. Because just disrupting the part of the brain that's been malfunctioning with the swelling, patients typically, not everyone, but typically they feel really good for about 3 days up to a week, maybe a couple of weeks if you're lucky. And so they want to run around and do all these things. So just remind them to rest. They're obviously allowed to get up and do things. They will feel pretty good, but we don't want them lifting, bending, twisting, all the normal things that you're not supposed to do after surgery. Remind them to stay hydrated. Parkinson's patients have a little bit of trouble with anesthesia, no matter what type of anesthesia it is. Typically, if you're having it done, by movement disorder specialists, your anesthesiologist already knows that and is giving you the best combination of medications to make it as light as possible. But still, they're going to feel that lingering fatigue. And the more that you can stay hydrated, flush things out of the system, the better. Also, dehydration tends to make Parkinson's patients feel a little bit worse. So it's a good idea to stay hydrated. My biggest message to everyone is to keep everyone from picking at things or keep them from hiding things. I know we don't like our bare heads, and especially up here in Ohio, it gets really cold in the winter. And so we want to put all kinds of hats and all kinds of things, hats, wigs, scarves, everything on your head. That's fine. Just please, please, please make sure it's clean. Remember, those incisions are new, and after you've gone through all this hard work, the last thing in the world you want to happen is for that to become infected. So you can, if you can, please rock your beautiful hair or lack thereof. But if you want to put something on top of it, please just make sure that it's very clean. And always, please, as little as possible, touch those incisions. Try not to touch things. I know they itch and they burn and they feel funny, but the less touching, the less risk for germ infection. And then just my last tip, and something that we sometimes forget to tell patients until afterwards, is get your teeth cleaned right before you have surgery. And this is not true of all sites. The research and literature has gone back and forth, but it's not uncommon for us to ask you to have no dental work, including cleanings, for 6 months after surgery. Again, not all sites, this can be different from place to place, but it is something that happens and we're kind of bad about reminding you about. So set them up a nice appointment for the dentist to have their teeth cleaned right before surgery, so then they won't have to worry about it. And then the other thing is, anytime, this is also site specific, it depends, but again, the literature has gone back and forth, but oftentimes you will need an antibiotic if you're having dental work done. So not a typical cleaning per se, but after that 6-month period has passed, if you're going to have some serious dental work, or even some mild dental work, everything is, people ask me why, everything's connected. Your mouth and sinuses are connected up here. And so, it's just another precaution to keep germs away from places they shouldn't be. Okay, I think this is my last slide. Next slide, please. I might have one more. Okay, so afterwards, as a caregiver, the best thing you can do is remind everyone, including yourself, patience. Because after we have this, we want immediate results. And I do not blame anybody who feels this way. Everyone feels this way, because you have just gone through a very long process to even get to the surgery. And then afterwards, you're exhausted and you're waiting for this thing to work. So we do have to program this device. And it takes us a little while, especially with the new technology that has come in the past couple of years. It takes us a little bit longer than it used to, but we have fewer side effects, and a lot more options, which is a good thing, not a bad thing. So just bear with us. Your initial programming is probably the last time, and the last time your care partner is going to feel terrible. So try to be kind to them that day. It's the last time they should, hopefully, sometimes we have to do it a few more times, but be off meds for 12 hours. So you know how miserable everyone is when they're off meds. So if you can bring them snacks and water and realize that they're going to get terrible sleep the night before and they're going to be anxious and worried. So if you can just be calm, cool, collected, snacks, water, bring the meds with you, have everything, that will take so much weight off their shoulders that will be so helpful for them. You're of course going to drive that day. They're not going to be driving that day. They usually can't drive up to 6 weeks after surgery anyways, but you should be driving for these first initial programmings. And then if you're coming from really far away, you might want to consider staying somewhere. I know with COVID, that's a little tricky, but if it's a long drive back, they're going to feel really punky that day. So results aren't instant. I know there's a lot of Facebook and YouTube videos out there showing that tremor starts and stops, and it's fabulous. And it's true, but it takes us a little while to fine tune. And there's also some medication adjustments that we have to do. So you're going to feel way better after your first adjustment, but not that day. That day you're going to feel yucky and off meds, but the next day and the day after that are the days that you're going to feel really good, and happy that you did this. And then remember, we're going to keep tweaking things. We're going to see you back every 2 to 4 weeks for at least another couple of visits until we've got it fine-tuned. And then finally, when you're done with that, you will likely go back to seeing your provider every 3 to 6 months. Things will be boring. They will slow down. Sometimes we will adjust your stimulator. Sometimes we won't have to adjust the stimulator. We'll be keeping an eye on your battery for when it needs changed, but the worst is over. So if you can get through initial programming, that is when the corner really starts to turn and everybody starts to feel better. I did want to mention one more thing for initial programming, that it's a long day, and you will be there a long time. So even sometimes after we're done programming, we'll often have you take your medications and then you have to wait for them to kick in. So just so you have an idea that this could be a 2, 3, hopefully not 4-hour process for you, and that it's just a long day to be prepared for. Yeah. As their care provider, if you could, or just care partner, if you could monitor their symptoms in between. Sometimes they're feeling so good that they forget to tell us, oh, I'm a little dyskinetic, or, I'm wiggling some, or, oh, I had tremor, but it's not as bad. So, people will say, no, I feel great. So if you can just monitor some of those things, help us out with the medication changes. And then just don't be afraid to send us a message in between visits. These are the messages that we pay close attention to everything, but particularly these. We know you're new to DBS, and it gets confusing, especially early on. You will have some ability with your patient programmer to adjust things up or down, or on or off, and some different things. So if you have questions, if you're feeling uncomfortable, if you really think you know what you're supposed to do, but you're not sure, just send us a message or give us a call. That's what we're here for. We'll get back to you, and we can help you feel more comfortable. It will eventually be just like getting your cup of coffee in the morning when you have to use that patient programmer, which is pretty rare. But the first couple of times, it's pretty frightening to think that you are adjusting something in your loved one's brain. So we understand that and are happy to talk you through whatever you need to do. So just the follow-up programmings, they're much shorter, 30 to 60 minutes, much easier on the patient. They don't often have to come off medications. The adjustments are smaller, and then everything kind of goes back to normal, and everybody feels better. If you feel like your loved one is not bouncing back quite as fast, but they're doing better, we always recommend a round of physical therapy. As one last thing kind of from this process is to just get them up and moving, and feeling a little bit more like themselves. So that's again, hopefully one last thing to have to get through during that time. Okay, I think I am finally done.
Clarisse, that was fantastic. Yeah, that was a lot of material you got through, and all super relevant to our care partners. So speaking of care partners, we would now like to welcome some of our lovely volunteer care partners, all of whom have a loved one with DBS. We've got Jackie Wilson, Sue Bellassai, and Kay Russell. And what we're going to do is to ask each of the three of them to briefly share their own DBS experience in terms of what led them to the decision to have DBS and the impact that it's had on them and their loved one. And then immediately after that, we're going to invite our audience to ask questions of the panel. So continue submitting those, and we'll take them either live after the panel presents, or I'm happy to share those questions that you put into the chat. So with that, I'm going to ask Jackie to start, and then she'll turn it over to Sue and then to Kay. So go ahead, Jackie, if you want to unmute.
Sure. Thank you for having me. My husband, Glenn, is my loved one that has Parkinson's and has DBS. He was first diagnosed young onset in 2003. In 2003, his symptoms were very, very mild. He had tripped a couple times, and he started having a tremor in his pinky. When you saw him then and you see him now, he looks really more like a stroke patient in a way, because if his meds are off, his arm is rigid, his left side was initially more affected, and then transitioned to his right side. He later went with the right side. He does have a slight tremor in his right hand. His local neurologist began talking to us, and he had connections to. We're located in Marion, Virginia, which is in Southwest Virginia, and his local neurologist suggested that he talk to someone about DBS. Because he had connections down in Winston-Salem at Wake Forest. And so he started thinking about that, a little intimidation, the whole thing of drilling holes in your head and things like that. But we were able to talk with someone. It's actually a connection through our niece about that. And that personal conversation probably made the difference for him. Someone who had young onset, who had experienced DBS, and what it had done for their lives. So that was very key. Glenn had his first DBS surgery in 2014 for his left side. He tells the story that, and he's not with me, I'm at work, he's at home. But he tells the story that when they, in surgery, he recalls that when they started adjusting it, that immediately his left side relaxed. He said, it's like when you lay down in bed and you take a deep breath, and it's like you're just, and so, it really was amazing for him because of how stiff and rigid that left side was. So first one was in 2014. In 2015, he developed Lyme's disease, and diagnosis took a while because he didn't have the bullseye that's typical with Lyme's disease. And so after 2 weeks, he had Bell's palsy. He had, I could tell that his Parkinson's was a lot worse. He wasn't sleeping. And by the time we actually got a diagnosis, it was on a Tuesday. By Thursday, he was almost unable to move. I had to roll him into the doctor's office. He was admitted into the hospital, spent a week in the hospital and 2 weeks in rehab. So that was a setback in spite of the DBS. You know, he received tremendous improvements with the DBS to that left side. You really couldn't tell. You couldn't tell that, you know, that rigidity, that stiffness was drastically improved. Lyme's disease, I think Clarisse mentioned that the physical therapy. Well, the spring of 2016, we scheduled his right side DBS, and he still hadn't fully recovered from the Lyme's disease. Just really, I like to say that the Lyme's disease just kind of pulled that Parkinson's to the basement. You know, he was just really struggling. So 2016 had right side, followed by a LSVT, which the combination was life-changing. I remember at the end of, it was literally within the time that he was recuperating from the surgery, you know, after the 6 weeks, but still, that he started the LSVT. I remember thinking, he's back, you know, he's back to normal. And that was such a tremendous feeling. You know, when I think about the DBS journey for us, you know, it allowed him, he was in the prime of his career. You know, he was, we still had children at home when he was diagnosed. And so it allowed him to continue to do things, both with our family, but also to work and to work outside. He's worked outside all his life, but he loves that. And so if I could say the things that DBS did for him, obviously the initial impact of just the improvement that he received. And then to allow him to be able to continue to work to retirement. You know, if one of the things that he struggles with, I think, you know, I think his settings are pretty high, but is that his battery does have to be replaced. I don't want to be a Debbie Downer because it really made a difference in his life. His battery typically will only last maybe a year and a half. During 2020, he actually had 2 battery replacements, and he has a Medtronic device. Not maybe I wasn't supposed to say it. But they went from 2 devices to 1. And so that was with the new technology. And so that was very much encouraging. I'm going to pass it off to Sue now.
Hi, I'm Sue Bellassai. My husband Angelo and I live in the center of the country. We live in Olathe, Kansas, outside of Kansas City, Missouri. So we go to KU Med Center for Angelo's care. And he also was diagnosed early. He was 51 when he was diagnosed in 2002. And at the beginning, we didn't really believe the diagnosis because his symptoms were his shoulder was stiff, and then his hand became stiff. And, you know, eventually we had to agree, and he started medications. And over the next 10 years, it just kept going downhill and upping the medications until he was taking 12 of the Cinemet minimum a day. And if he had meetings at work or things happening, he would take extra just to try to get through. But even with all of the medication, his symptoms were up and down all over the place, big roller coaster. It would work and then it wouldn't work. So we started hearing about the DBS, and it was scary. He thought about it, and finally in 2013, decided, yes, let's do it. And I want to reiterate Clarisse's mention of patience, because it's a process. He did 2 of them. We were going in with the idea of doing 2. And but after all the testing, and then you finally get on the schedule, the first one was scheduled for June of 2014. And we had that one. Everything was going well. We had a little hiccup. He went back to start the second one in, I think it was July. And one little place on the first one had not fully healed. So we said, well, there was no infection, no big problem. There can be hiccups, and this was our hiccup. And so we decided to put off the next surgery. It didn't happen until November because of scheduling and things we had going on. So he had that second one in November, and then we got to have programming right before Christmas of 2014. And it was miraculous for us. He went down, once we got through that scheduling phase of 3 to 4 months, you know, getting the appointments, doing what they ask us to do, he went down to 3 pills a day. And now 9 or 7 years later, I guess it is, he is still on only 3 Cinemet pills a day and had dropped off a lot of his other medications. And I'm sorry that Jackie and her husband are going through more battery changes, but my husband, he had his first change this past January. So his batteries lasted 6 years. And we were grateful for that. So he's doing very well. He walks, 2 miles or so at a time when we go for long walks. So doing well. Thank you. I'll hand it to Kay.
I'm Kay Russell, and we're from St. Paul, a suburb of St. Paul, Minnesota. Jim was diagnosed with Parkinson's 16 years ago, and he did fairly well until about 6 years ago. We went to a new doctor, and she says, do your feet move a lot? And Jim said no. And so we continued the visit, and she finally at the end said, well, since you've been here, your feet haven't stopped moving. Have you thought of DBS? And it was like, whoa. Well, he took about 6 months to think about it. And we came to the conclusion that, yes, it was the right thing to do. Our surgeon did the 2 sides at one time. And for us, that worked out wonderful. He does have the rechargeable battery, but so he had his 2 sides done at once. When he came home, his first shower, he said, that was the best shower he had in years. He after his surgery, he dropped, his medicine went down 40%. Well, it's climbed back up there. He's on a lot of medicine, and he can tell when he's off his meds. He can tell right away. So he's taken a lot of extra meds, the carbidopa. The one thing was last year, we started a DBS support group here, and it has gone over really well. We've had it for about, I guess 2 years, but then we had that year off. We schedule 4 meetings a year, and I have 2 scheduled coming up in September and September and November, and we do it at our local library. And they've been very good with helping us make sure that they always keep a day open for us. And we have brought in different speakers, and that has worked really well. So I encourage you, if you need to, start a support group, because I think we all need that support. So I'll pass it on back to Kim.
Thank you, Kay. And I love that. And we thank you for what you're doing for the DBS community there with that.